Hello, everyone, and welcome to our World EoE Day webinar. This is an exciting day for us. It's all coming together for this particular day. Unite for EoE, food shouldn't hurt. My name is Stephanie Williams. I will be moderating for you today. I wanted to let you know, first of all, that we do have Wordly translations available. And Victor has been kind enough to share this link in the chat. So you can go to the chat, click on the link, and open it up, select your language, the language that you would prefer to read or listen to, and follow along with us in real time. Two of our presenters today will be delivering their presentation in their own language. So we will be hearing from Dr. Racca in Italian and Dr. Lucendo in Spanish. So everyone will need to have access to Wordly today before we begin. I would also like to offer, if anyone has questions during the presentations, you feel free to type them into the chat. We are monitoring the chat for those questions, and we will be able to share those with each of the presenters at the very end of our discussion today, if there is time available. So it is my pleasure to introduce our three speakers today. The first, Dr. Francesca Racca, is a physician at Hospital Humanitas Gavasenza, I'm so sorry, Gavasenzi in Italy, and with a strong focus in eosinophilic gastrointestinal disease and patient care. She is well known for her work helping improve awareness, diagnosis, and multidisciplinary management of EoE. Welcome, Dr. Racca. And we also have Dr. Evan Dellon. He is an internationally recognized gastroenterologist and one of the leading experts in eosinophilic esophagitis at University of North Carolina at Chapel Hill in the United States. Through both research and clinical care, he's helped shape how EoE is understood and treated around the world. And welcome to you, Dr. Dellon. And then we are honored to have Dr. Alfredo Lucendo. He's a globally respected expert in eosinophilic gastrointestinal disorders at the Hospital General in Tomelloso, Spain. A prolific researcher and educator, he has played a major role in advancing international knowledge and clinical guidance for EoE. So I welcome you all to this wonderful day, and we will start with Dr. Racca. So Dr. Racca, I'm going to stop sharing my screen so that you may share yours. And then we just make sure that I can hear you before I leave the screen here.
So thank you for the kind presentation and welcome and buon pomeriggio a tutti. I will switch to Italian for Italian patients. Buon pomeriggio a tutti e inizieremo a parlare di manifestazioni atopiche nell'esofagite eosinofila. Prima di tutto, incominciamo a chiederci perché è così importante parlare di manifestazioni allergiche nei pazienti con esofagite eosinofila. La ragione è molto semplice ed è manifesta a tutti quelli che si occupano di esofagite eosinofila perché la stragrande maggioranza dei pazienti con esofagite eosinofila in verità presenta anche manifestazioni allergiche e altre malattie che noi chiamiamo infiammatorie di tipo 2. La prevalenza di queste condizioni allergiche è estremamente più alta nei pazienti affetti da esofagite rispetto ai pazienti della popolazione, alla popolazione generale. Abbiamo una prevalenza, quindi un numero di casi 3 volte superiore per quanto riguarda patologie come la rinite allergica, l'asma e la dermatite atopica. In generale si stima che dal 53 all'80% dei pazienti con esofagite presenti anche allergie e le più prevalenti sono quelle agli alimenti. Le allergie alimentari hanno una prevalenza dalle 5 alle 10 volte superiore nei pazienti con esofagite eosinofila e anche la poliposi nasale ha una prevalenza aumentata di circa 4 volte. L'altro lato della medaglia è anche interessante perché proprio i pazienti che presentano allergie o malattie atopiche presentano una prevalenza di esofagite eosinofila molto più alta anche loro rispetto alla popolazione generale. Come vedete, abbiamo nei pazienti affetti da asma, da rinite allergica e da dermatite atopica, abbiamo una prevalenza dalle 2 alle 3 volte superiore di esofagite eosinofila rispetto alla popolazione generale, scusate, e la prevalenza arriva anche a 8 volte, a essere 8 volte superiore nei pazienti con la dermatite atopica o la poliposi nasale, e addirittura 40 volte superiore nei pazienti che presentano allergie alimentari. Questo è uno studio molto interessante che è uscito qualche anno fa ed è interessante perché ha seguito più di 1.000 bambini dalla nascita all'età di 10 anni e ha monitorato lo sviluppo di malattie allergiche di esofagite eosinofila. E come potete vedere, il rischio di sviluppare esofagite eosinofila è dalle 2 alle 3 volte superiore nei bambini che hanno iniziato a presentare rinite allergica, asma o dermatite atopica e addirittura 9 volte superiore nei bambini che avevano allergie alimentari. E non è l'unica risultato interessante di questo studio, perché l'altro risultato è che più malattie allergiche ha lo stesso bambino e più aumenta il rischio di sviluppare esofagite eosinofila. Infatti, un bambino con la sola dermatite atopica ha un rischio, per esempio, di 3 volte superiore di sviluppare esofagite eosinofila, ma un bambino che ha 2 o 3 comorbidità insieme, facciamo l'esempio, la dermatite atopica, l'asma e la rinite allergica, in verità non ha un rischio 3 volte superiore come sarebbe quello se avesse solo la dermatite, ma ce l'ha di 9 volte superiore. Questi risultati hanno portato all'inserimento dell'esofagite eosinofila in quella che noi allergologi chiamiamo marcia atopica. La marcia atopica è una teoria allergologica che dice che i bambini che sviluppano nelle prime fasi della vita la dermatite atopica sono a rischio e di solito continuano la loro marcia allergica sviluppando inizialmente allergie alimentari, poi l'asma e la rinite allergica e infine adesso sappiamo che il rischio è che sviluppino anche l'esofagite eosinofila. Questo perché accade? Una delle principali spiegazioni è che l'esofagite eosinofila e le malattie atopiche hanno la stessa base genetica. I nostri pazienti sono geneticamente predisposti a sviluppare queste patologie e i geni che aumentano il rischio di diventare atopici o di sviluppare l'esofagite eosinofila sono in comune. Molti di questi geni infatti sono condivisi, come vedete, tra le varie patologie allergiche e possono essere raggruppati in due gruppi principali. Il primo gruppo di geni si occupa di quella che è la barriera epiteliale, cioè la barriera che consiste nella pelle, nelle mucose del tratto respiratorio e gastrointestinale, che ci difende da tutto quello che sono le sostanze ambientali potenzialmente nocive. Nei nostri pazienti questa barriera non funziona bene, c'è una disfunzione di barriera che, come vedremo, è uno dei motivi principali per cui si attiva il sistema immunitario. Il secondo gruppo di geni riguarda l'infiammazione di tipo 2. L'infiammazione di tipo 2 è un'infiammazione che originariamente ci serviva per combattere i parassiti e alcuni altri patogeni, ma quando è fuori controllo, contribuisce all'infiammazione tipica delle malattie allergiche e i nostri pazienti sono geneticamente predisposti a produrre più molecole infiammatorie che proprio facilitano lo sviluppo di questo tipo di infiammazione, che è poi quella che noi vediamo nelle patologie allergiche e anche nell'esofagite eosinofila. Abbiamo parlato del danno di barriera, del difetto della barriera. Il difetto della barriera è importante perché è il primo stadio di tutte le nostre patologie. Il difetto di barriera, quello che fa è facilitare la penetrazione degli antigeni, quindi delle sostanze esterne, attraverso la pelle, attraverso le mucose. Qui, come vedete, c'è l'esempio di una bella foto in giallo, vedete degli antigeni alimentari dentro la mucosa di pazienti con l'esofagite sinofila, ma non sono solo gli alimenti. Qui in rosso sotto vedete anche allergeni degli acari della polvere che riescono a penetrare quindi le nostre barriere e a scatenare quindi quella che è l'infiammazione di tipo 2. L'infiammazione di tipo 2 si scatena perché l'entrata degli allergeni attraverso le nostre barriere mette in allarme il nostro sistema immunitario, che quindi produce delle molecole che si chiamano proprio allarmine, che attivano il sistema immunitario che per combatterle dà inizio all'infiammazione. Le molecole dell'infiammazione poi richiamano varie cellule dell'infiammazione di tipo 2 e quella che conosciamo meglio e conosciamo tutti è l'eosinofilo che si accumula nei tessuti ed è quello che vediamo nelle biopsie dei nostri pazienti, ma anche nelle altre manifestazioni allergiche, nelle altre malattie infiammatorie di tipo 2. Una domanda che mi fanno molto spesso i pazienti è: ma data questa associazione, le allergie possono influenzare l'esofagite sinofila? E la risposta non è così chiara, dobbiamo ancora lavorarci un po', però un po' di cose le sappiamo e una teoria dice che effettivamente le allergie potrebbero avere un'influenza sull'esofagite sinofila. Quello che sappiamo da molto tempo è che, per esempio, la diagnosi di esofagite sinofila viene fatta molto più frequentemente tra la primavera e l'estate rispetto al resto del periodo e che questo picco nelle diagnosi effettivamente correla con la conta pollinica, specialmente delle graminacee. Eh, Però quando poi andiamo a vedere quanti dei nostri pazienti effettivamente hanno un aumento degli eosinofili durante il periodo pollinico, con una concomitante riduzione di queste cellule fuori dal periodo della stagione pollinica, ci sono dei pazienti che effettivamente rispondono a questi criteri, ma come vedete sono una minoranza di pazienti, si parla negli studi del 2-3% dei pazienti. Uno studio più recente che ha poi però riaperto molto questo dibattito sul ruolo degli allergeni inalanti nell'esofagite sinofila è questo studio molto carino, svolto in Italia e nel Regno Unito, che fa vedere che nei pazienti che stanno facendo una dieta di eliminazione, la Six Food Elimination Diet, la dieta dei 6 alimenti, se io misuro la loro risposta alla terapia nel periodo pollinico, in pazienti che hanno i test allergologici positivi per i pollini, beh, la risposta alla dieta è molto minore se io faccio la gastroscopia durante il periodo pollinico rispetto alla risposta che invece misuro se faccio la gastroscopia fuori dal periodo pollinico. Ma quindi trattare le altre allergie può beneficiare o influenzare l'esofagite sinofila? Su questa domanda la risposta non c'è. Non ci sono studi che hanno valutato questa cosa nell'esofagite sinofila, però un po' di cose le sappiamo sulle altre malattie allergiche. In particolare, per esempio, sappiamo che curare in maniera attiva i bambini affetti da dermatite atopica riduce significativamente il numero di bambini che poi diventeranno allergici all'alimento. a degli alimenti e come abbiamo visto l'allergia alimentare è un fattore di rischio abbastanza importante per lo sviluppo di esofagite eosinofila. E l'altra cosa che sappiamo è che effettuare l'immunoterapia allergene specifica nei bambini affetti da rinite allergica riduce notevolmente lo sviluppo di asma in questi bambini durante la crescita. Se questi due fattori possono poi effettivamente influenzare l'esofagite eosinofila, è sicuramente un tema poi da approfondire in futuri studi e non abbiamo ancora tutte le risposte. Quindi, per concludere, è importante capire che il paziente che presenta esofagite eosinofila o altre malattie allergiche deve essere sempre inquadrato in maniera totale e chiunque manifesti una patologia atopica, compresa l'esofagite eosinofila, va sempre valutato per vedere se ci sono altre manifestazioni atopiche che vanno trattate insieme all'esofagite per aumentare la qualità della vita di tutti i pazienti. E questo si può fare grazie alla collaborazione tra vari specialisti e anche con i pazienti, perché voi siete una parte importante. Grazie.
Dr. Racca, thank you so much for a lovely presentation. We already have several questions coming in, so I think you can probably expect to get some of those at the end of the hour.
With pleasure.
Dr. Dellon, I would like to turn it to you and make sure that you're able to share your screen.
Yes, I can. Can you see those?
There it is. Perfect. Thank you so much.
Okay, terrific. Well, thank you, everyone. And it's a pleasure to be here to help spread awareness on World EoE Day and be with such a great group of speakers and talk to you about epidemiology and diagnosis of eosinophilic esophagitis. I do have some disclosures. I work with a lot of companies that help to develop drugs for EoE, but these disclosures aren't really pertinent for this talk. What I want to do today is provide an update of epidemiology of EoE, talk about how this increase in EoE may suggest some risk factors, and review how we diagnose EoE. So sort of two separate topics for today. And we can start with epidemiology. So first off, what is epidemiology? It's really the study of patterns of a disease in population, so how common they are, how they may be changing or going up and down, and what may cause those diseases. And so we know for EoE now with many studies that it's a condition that's a chronic, lifelong allergic condition, as you just heard. It can affect anybody at any point in life. There does interestingly seem to be a male predominance to this condition, which we don't really understand. And it can also occur globally in all racial and ethnic backgrounds, though it does seem to be more common in whites. And again, the reasons for this are pretty unclear. You just heard the very strong association with atopic disease, and there can be some increased risk in certain families. Now, how common is EoE? This is what the basic parts of epidemiology will tell us. And the prevalence is how common EoE is right now at any given time. How many people have it? And this is a study of EoE cases over the last 50 years across the world. And it has patients, it looked at all the papers, and you can see in the light and dark blue countries where EoE has been reported, and you can see this steady rise in the number of cases around the world. And they're estimating at about 40 per 100,000 as an average over the last 50 years. But if you look more closely at the most recent year, it's more than twice that. And that rate, 80 to 100 per 100,000, is about one in 1,000 or so. And then the incidence, this is how many new cases are there over a given period of time. And here this average is about 5 per 100,000. But we can go a little bit more into these depths and not necessarily look at averages, but look at a snapshot of what's going on now. So these are some data from the United States, which are pretty similar to other parts of the developed world right now, including Europe, Australia, and parts of South America where this has been looked at. And you can see here over the last 15 years, this really rapid increase in EoE in two different data sources. And if you average it out, it's about 1 in 700 now in the US. So about 500,000 people with a known diagnosis of EoE. And you can also see in this graph the males versus the females. It's more common in males and females, but you can see that anybody of any age can get it. And if you look at the change over the last 15 years, you can see the marked increase, really a dramatic rise in every age group and in both sexes over that time period. Now, even though it's rising so much and we know about all of these cases, this is probably just the tip of the iceberg. And this was an interesting study that was looking at how many people with EoE come to the emergency room and what can we think about trends in those patients. And they found about 50,000 people having an emergency room visit for EoE. And this was predicted to double if you plot that out over the next 10 years. But the interesting part of the study is actually over here on the right side. The researchers asked the question, well, how many people come to the emergency room who have trouble swallowing or food impaction or an esophageal stricture, common things in adults with EoE, but who are under the age of 40 and just men? And they found 700,000 people like this who did not have a diagnosis of EoE. And there's not that much in this age group that would cause you coming to the emergency room with trouble swallowing or a food impaction or a stricture. And so I just told you there might have been 500,000 people in the US with EoE, but this suggests that there may be twice as many as that who are undiagnosed with EoE. And so I think we're seeing more and more of this. Because, in part because of this kind of session getting the word out, but also because the EoE is increasing so much. Now, those numbers I just told you are sort of general population numbers. So general population, if we counted everybody in a given area, maybe 1 in 700 or so. And that's what these studies on the top are. But if you ask how common EoE is in other kind of settings, it can be a lot more common. So for example, if you're getting an endoscopy for any reason, an upper endoscopy, EoE is found about 6.5% of the time. And if you're getting an endoscopy for trouble swallowing, depending on where you go, it may be seen 15 to 23% of the time. And if you happen to come to the emergency room with a food impaction, so food stuck and it can't go up or down, that's the EoE is the number one cause of that, and you'll see that EoE more than half the time as the cause of that presentation. And then you also just heard from Dr. Racca that people with allergic diseases have a much higher chance of having EoE as well. So that's a very high prevalence kind of setting as well. Now, what about the trends for how many new cases each year we're having? And this is data actually now from more than 30 years, but you can see no matter where these are different places in the country, and this is how the rate of new diagnoses of EoE, no matter where you are, the rates are increasing rapidly. So it's not slowing down. We're seeing more and more new cases diagnosed every year. And so this really, brings the question is why is this happening? And is this a true increase? Like, is the disease increasing rapidly on its own? Or is it just because we know more about it and we're doing more procedures to diagnose it? And so I was able to do a study in Denmark, actually. And in Denmark, everything is linked from the health system to the citizen level. And so we could actually find everybody in the country who had a diagnosis of EoE and everybody in the country who had an endoscopy and biopsy. And what we saw here in the blue line is that the rates of EoE were going up, but also the rates of endoscopy and biopsy were going up, but they were going up at different speeds. The endoscopies and biopsies doubled over 15 years, but EoE went up by 25-fold. And so there is a component that we know more about the disease, we're looking for it more, and that's one reason we're diagnosing it more. But that's not the whole thing. It's increasing far faster than we're diagnosing it. And so that means there's something really going on. And this has been replicated in Switzerland and in Korea and in other places around the world as well. And so this seems to be a consistent trend. So what we know is with trends like this, it usually is not genetics that changes so quickly, right? Our genes do not change over just 20 or 30 years. That can take thousands of years or longer. And so most likely this is environmental changes. And this was a study that was done in Cincinnati, but involved many collaborators. And they looked at twins with EoE, and they asked the question of how common was EoE between twins. And in fact, you did see EoE more commonly in twins. So if you were identical twins, 41% of the time, both twins had EoE, but it's not 100% of the time. And they went on to do the analysis and felt that there was only about a 15% genetic impact for EoE and an 85% impact on the environment. The other thing this study suggested, which is often asked to me by my patients, which is, I'm a parent. What's the chance my child is going to have EoE? Or what's the chance my sibling may get EoE? And they found that about 2% of siblings or parents to children would get EoE. So that's the risk. That really shows that it's not a primarily genetic condition. That is higher than the general population, which you could see here at this time. So there is higher risk within the families, but certainly it's not the high risk like we would see 25%, 50% with traditional genetic diseases. So then the question really is, well, what's going on in the environment and why is EoE increasing so much? And there are lots of things that have been studied. Some possibilities are the hygiene hypothesis, right? That we're growing up and living in a place that's too clean, and the H. pylori infection in the stomach, that's been decreasing at the same time EoE has been increasing. This is a map showing population density, and EoE tends to be more relatively common in areas of low population density, like rural areas here. So in the US, this is North Dakota. Not a lot of people live there, but if you happen to live there, you're at higher risk for getting EoE. And other environmental factors like poor environmental quality, proximity to large farms, these have all been linked to EoE now, and so have early life exposures, things that happen to babies in their first year of life, like being born prematurely or getting a lot of antibiotics. Those are all things that seem to predispose not only to EoE, but also other allergic diseases. So when we think about EoE and the change in EoE, it's not just environmental factors. These environmental factors here might interact with things that happen early on in life. You just heard about the lining of the esophagus, the defective barrier, and these environmental factors interact with that. And then, of course, there is genetics that gets interacted. So it's a complicated set of factors that come through to cause EoE and cause this change in epidemiology. Now, the other thing, as we'll hear a little bit later about treatments for EoE, is that think about EoE as a chronic condition that in many people will progress from a lot of inflammation to scar tissue in the setting of some ongoing inflammation. Now, this is not universal, but there are studies that have shown that as you have longer and longer periods of symptoms before you're diagnosed, you have more chance of getting strictures. So these are data from Switzerland. This is the longer that you have symptoms before diagnosis. There's more black bars here, which indicate more scar tissue in the esophagus. This is from Switzerland. This is the same thing from the Netherlands. As you have more and more symptoms, time before you have diagnosis, more and more food impactions and more strictures. The other thing that people ask is, okay, well, if EoE is chronic and if it's an inflammation condition of the esophagus, could it cause esophageal cancer? And the good news is to date, there has not been any evidence for EoE leading to esophageal cancer. These are just two studies that did not find any increased risk of cancer in esophagus cancer in EoE. So I think that's reassuring for many people. And I just wanted to present some of those data. So in the last few minutes, let's change and talk about how we diagnose EoE now. And we do have a very structured diagnostic criteria where you have to have symptoms of EoE. This will lead to getting the upper endoscopy with the biopsy. If there's at least 15 eosinophils in a biopsy, you can consider the diagnosis of EoE. But we still have to look for other possible causes of those eosinophils in the esophagus. And once we're convinced those aren't present, then we can diagnose EoE. And just briefly, the symptoms for most adults and adolescents are trouble swallowing and food sticking. And the thing here is that many people will eat carefully to minimize their symptoms without actually realizing they're doing it. And so we often ask about what's called the impact behaviors, which are eating behaviors that really minimize symptoms. And this is like imbibing or drinking a lot of fluid during meals to help get foods down, modifying foods by taking small bites or pureeing them, eating slowly, prolonging meal times, avoiding foods that stick, chewing really carefully to help foods get down, and a subtle symptom is having trouble swallowing pills. So those are the things that we think about mostly in adolescents and adults. And then in children, you can have a lot of non-specific symptoms, abdominal pain, nausea, vomiting, failure to thrive. And then some people will get heartburn and chest pain kind of symptoms that are not due to reflux or due to other problems. When we do our endoscopy, we use the EoE endoscopic reference score, or EREFS, to get a sense of what the endoscopic findings are. And these are some examples of some of the findings you can see. There's edema. The esophagus is really swollen. There's rings. These are sort of the classic findings of the esophagus. It almost looks like a trachea. That's scar tissue. You can see exudates. This is the white spots, highly indicating a lot of inflammation in the esophagus. And you can see furrows, which train track up and down the esophagus. And then there's also strictures. So this is a narrowing, a focal constriction of the esophagus, and you can understand why food gets caught on there. That's smaller than a small coin in this particular patient. And then this is what it looks like when we take a biopsy in the esophagus. These are the little forceps that are coming out from the front of the scope. We open them up. We apply them to the lining of the esophagus and grab a small piece. We try to go right across a furrow here. It's a very high yield for the biopsy. And then you can see just a very small piece is taken off there. And that's what we go to look at under the microscope. And generally, your doctor will get at least 6 biopsies and sometimes more to make sure they're picking up the possible diagnosis. And then, like I said, that third step, we look for other causes of eosinophils in the esophagus. And for you to know, reflux is really the most common thing we need to distinguish from EoE and evaluate for. Could be present, but it has similar symptoms to EoE. It causes a lot of need for endoscopy, and it can cause some diagnostic confusion. And then, doctors will go through and look at these other conditions on here and make sure that those aren't present. And I just wanted to show one last slide here of other findings that could look like EoE, but these are all different conditions that are not EoE. And so this is some yeast infection in the esophagus. This is Candida. This is actually Crohn's disease affecting the esophagus. This is something called esophagitis dissecans and pseudodiverticulosis. And these are examples of lichen planus and lymphocytic esophagitis. So it is really important to think about that third step because there are things that look and act like EoE that end up not being EoE and have very different treatments. And so that's a really important thing that we want to think about for EoE diagnosis. So to sum up, EoE is diagnosed when we have the right symptoms, when we have those eosinophils on the biopsy, and when there's nothing else going on that would confuse everything. And then the prevalence and how common EoE is really increasing rapidly. This is actually no longer a rare disease, 1 in 700 or more. And this is what you would expect because this is a chronic lifelong disease, and happily it doesn't shorten lifespan. And so the more people get diagnosed, they're going to be rapidly accumulating more and more people who are living with EoE. We're starting to identify the risk factors, and we're seeing this signal for environmental and early life exposures as risk factors. But we need a lot of work to be done still, and we have to start to understand at an individual patient level what those risks are and how they might cause EoE. So thank you so much. I just wanted to point out egidpartners.org. This is a global patient-powered research network, and so patients can join. Please check it out. It has information for you, but also it collects information about your condition in an anonymous way, and you can suggest research topics, and researchers and patient advocacy groups work together to answer research questions that are important to patients. So you can join if you have EoE or another eosinophilic GI disease, and you can actually join if you don't have one of those, and you could be a control, and you could partner with us. So thank you so much for the opportunity to talk today. Very much appreciate it, and happy World EoE Day.
Thank you so much, Dr. Dellon. As a mom of a child who we've been going through this process and trying to get diagnosis, it's really lovely to see all this background information. So I appreciate you for presenting that today. Thank you.
Thank
Dr. Lucendo, if I can check and make sure that you're able to share your screen. There it is. Very good.
Okay. Thank you very much, Stephanie, for the next presentation. Muchas gracias a todos por estar aquí. Muchas gracias a los organizadores del Día Mundial de la Esofagitis Eosinofílica por contar conmigo para este evento tan importante. Es para mí un privilegio poder participar un año más y compartir este día con compañeros tan relevantes como los doctores Francesca, Racca y Dellon. Bueno, mi turno es hablar sobre los tratamientos farmacológicos para la esofagitis eosinofílica. Dejamos fuera de esta presentación los tratamientos dietéticos que ya se trataron en años anteriores. Diapositiva muestra mi conflicto de intereses respecto al contenido de esta charla, y es que yo he estado involucrado en el desarrollo de algunas terapias para la esofagitis eosinofílica. A lo largo de los próximos 15 minutos aproximadamente voy a dar algunas pinceladas sobre los objetivos terapéuticos de esta enfermedad, sobre las terapias de inducción y las terapias de mantenimiento, porque como ha advertido el doctor Dellon, es una enfermedad crónica que requiere un tratamiento a largo plazo. Bien, hoy consideramos que es esencial que todo tratamiento para pacientes con esofagitis eosinofílica contemple al menos estas 4 características: el control de los síntomas, el control de la inflamación, el tratamiento y la prevención de la reaparición de complicaciones, fundamentalmente complicaciones endoscópicas en forma de estenosis y esófagos de calibre estrecho, y la restauración y el mantenimiento de un nivel adecuado de calidad de vida. Hay otros objetivos terapéuticos relevantes que se están analizando en ensayos clínicos, como mejorar la funcionalidad del esófago a partir de mejorar su distensibilidad, revertir los cambios en la expresión genética y en algunos biomarcadores en esta enfermedad, mejorar la percepción de salud, y existen incluso otros objetivos que en este momento están en investigación. Este es un esquema que resume de manera gráfica los mecanismos por los que ocurre la inflamación en la esofagitis eosinofílica y que viene a complementar lo que ya ha mencionado anteriormente la doctora Racca. En un paciente con una susceptibilidad a presentar este tipo de enfermedad, la exposición a distintos componentes de la dieta generalmente o del ambiente produce la liberación de una serie de sustancias activadoras del sistema inmune llamadas alarminas, que actuando sobre células T da lugar a la liberación de ciertas citoquinas. Estas citoquinas producen cambios a nivel genético sobre distintos genes que están más o menos identificados en este momento, cuyo resultado final es una pérdida de la función de barrera del epitelio, la acumulación de eosinófilos en la mucosa, que son el signo histológico característico de la enfermedad, y la aparición de procesos de remodelado que van a llevar a la fibrosis y a la formación de estenosis a largo plazo. Los tratamientos dietéticos actuarían en esta primera parte, bloqueando la exposición de la mucosa a los factores desencadenantes. Por su parte, los IVPs y los corticoides que mencionaré a continuación actuarían en esta última fase de las cascadas inflamatorias, y en medio tendríamos la acción de los fármacos biológicos o del fármaco biológico que en este momento está disponible para el tratamiento de la esofagitis eosinofílica. Esta es la última guía publicada sobre cómo debe ser tratada la enfermedad, precisamente por el doctor Dellon, que nos dice que en un paciente con un diagnóstico establecido debemos considerar un tratamiento antiinflamatorio, y aquí habrá que discutir consensuadamente con el paciente o su familia si preferimos un tratamiento farmacológico de entrada o un tratamiento dietético. Dentro de los tratamientos farmacológicos tenemos los IVPs y los corticoides tópicos, y las dietas fundamentalmente se deben basar en esquemas empíricos, es decir, no realizando pruebas de alergia dirigidas a tratar de identificar el alimento. Cualquiera de estas 3 opciones se contempla en monoterapia, es decir, los pacientes reciben una alternativa y en principio no se combinan distintos tratamientos, salvo que un paciente pueda presentar, por ejemplo, una enfermedad por reflujo gastroesofágico de manera concomitante. Por empezar a desgranar algunos datos sobre estas terapias, vamos a hacerlo con los inhibidores de la bomba de protones, unos fármacos desarrollados en los años 80 para tratar algunos problemas relacionados con el ácido, que han demostrado a partir del estudio de la esofagitis eosinofílica presentar también un efecto antiinflamatorio intrínseco, independiente de este efecto sobre la secreción ácida. De hecho, los IVPs constituyen la alternativa de tratamiento más ampliamente evaluada en paciente con esofagitis eosinofílica. Contamos con muchísimos estudios desarrollados en distintas partes del mundo sobre adultos, sobre niños, que demuestran que estos fármacos son eficaces. En este artículo reciente nuestro grupo resumía los resultados de un total de 73 estudios que incluían a más de 7.000 pacientes y que de manera conjunta nos mostraban que los IVPs son eficaces para controlar la enfermedad desde el punto de vista de la biopsia, logrando tener menos de 15 eosinófilos por campo de gran aumento en un 45% de los pacientes aproximadamente. Y si nos marcábamos un objetivo histológico más ambicioso, tener menos de 5 eosinófilos por campo de gran aumento, esto se lograba aproximadamente en 1 de cada 3 pacientes. Sin embargo, aunque no se lograse siempre la remisión histológica, el beneficio sintomático era superior y 2 de cada 3 pacientes podían referir alguna mejora de sus síntomas tras el tratamiento con IVPs. Sabemos hoy día que la dosis máxima de IVPs a emplear en los pacientes con esofagitis eosinofílica es de 20 miligramos de omeprazol 2 veces al día o cualquier otro fármaco a dosis equivalentes. Aumentar esta dosis al cuádruple de la dosis estándar, es decir, 40 miligramos 2 veces al día, no produce beneficios adicionales y, por tanto, más allá de 20 miligramos de omeprazol 2 veces al día, no debería ser empleado. También sabemos que si prolongamos la duración de la terapia desde las 8 semanas anteriormente recomendadas hasta las 12 semanas, la probabilidad de alcanzar una remisión histológica aumenta de manera significativa. Ven ustedes que aumenta desde un 50 hasta un 65% la tasa de respuesta si aumentamos esta duración de la terapia. Y de hecho, la duración de la terapia era un factor asociado de manera independiente al éxito del tratamiento con IVPs. Sin embargo, sabemos que los IVPs no son eficaces en todos los pacientes y empezamos ya a identificar algunas condiciones o algunas características de los pacientes que hacen menos susceptibles a estos a responder a este fármaco. Así, aquellos pacientes que presentan al inicio un fenotipo estenosante, es decir, estrechamientos en el esófago que impiden el paso de un endoscopio, aquellos pacientes de edad más jóvenes, aquellos más delgados o los que presentan otras enfermedades atópicas concomitantes, incluida una elevación de eosinófilos en sangre periférica por encima de los valores normales, tienen menos probabilidades de responder a esta terapia. Y de hecho, cuantas más enfermedades o condiciones de este tipo se asocien, peor va a ser la respuesta a esta terapia. En este estudio en particular, presentar 3 o más de estas condiciones hacía que ese paciente tuviera una altísima probabilidad de no responder al tratamiento con IVP. La segunda alternativa terapéutica son los corticoides tópicos. Son fármacos utilizados desde hace décadas para manejar muchas enfermedades alérgicas que también se emplearon desde las primeras descripciones de la esofagitis eosinofílica en pacientes con esta enfermedad. A lo largo de la historia hemos empleado corticoides procedentes de distintos vehículos, incluyendo aerosoles diseñados para poner la medicación en el pulmón y no en el esófago, que debían ser tragados en lugar de inhalados, gotas nasales que debían deglutirse, líquidos para aerosoles, hasta fórmulas viscosas. Hoy sabemos que los comprimidos de acción tópica de corticoides son superiores a las fórmulas viscosas y cualquiera de estos es superior a cualquier corticoide administrado a través de sistemas de inhalación y por tanto estas últimas alternativas en este momento ya no son recomendables. Un análisis de más de 2.000 pacientes europeos tratados con corticoides nos mostró que aquellos que tienen menos carga sintomática, es decir, síntomas menos graves, aquellos que utilizan dosis más altas y especialmente aquellos que utilizan las mejores fórmulas disponibles, que son los comprimidos de budesonida bucodispersable, conseguían más probabilidades de éxito con este tratamiento determinado como probabilidad de alcanzar remisión histológica y sintomática. Tenemos este estudio realizado por nuestro grupo hace pocos meses que compara de manera directa e indirecta todas las presentaciones de corticoides que se han evaluado en el tratamiento de pacientes con esofagitis eosinofílica en la literatura con perspectiva histórica. En total son 20 estudios sobre casi 1.500 pacientes que nos muestran que comprimidos bucodispersables de budesonida tienen la probabilidad más alta de resultar la mejor alternativa sobre cualquier otra para lograr el objetivo terapéutico de tener menos de 15 a 20 eosinófilos por campo de gran aumento. Pero también esta alternativa parece que es la mejor si queremos plantearnos objetivos terapéuticos más ambiciosos, como tener menos de 5 eosinófilos por campo de gran aumento, o incluso si queremos normalizar de manera completa el aspecto de las biopsias esofágicas. El segundo grupo de fármacos son los biológicos. La verdad es que el interés en desarrollar fármacos biológicos ha crecido de manera progresiva en los últimos años según se iban descubriendo los mecanismos moleculares que mediaban la respuesta inflamatoria en los pacientes con esofagitis eosinofílica. De todo este listado tan grande de moléculas y mecanismos de acción, todos los que ven ustedes marcados en rojo se han evaluado en ensayos clínicos aleatorizados y comparados con placebo, pero hasta este momento solamente un fármaco marcado en verde, dupilumab, ha llegado al mercado. Es cierto que esperamos tener próximamente resultados favorables de estos dos fármacos, tezepelumab y surricutug, y que ojalá puedan unirse al arsenal terapéutico para la esofagitis eosinofílica. Vamos, por tanto, a hablar de dupilumab, un fármaco que está disponible para el tratamiento de numerosas enfermedades alérgicas, incluida la esofagitis eosinofílica, y aprobado en Estados Unidos, en Europa y en otras regiones del mundo para el tratamiento de esta enfermedad en pacientes de todas las edades, y que todavía sigue investigándose para otras posibles indicaciones futuras. El ensayo fase 3 es aquel que se realiza antes de la salida del fármaco al mercado y nos muestra que administrando dupilumab a una dosis de 300 miligramos por vía subcutánea cada semana, línea de color morado, se conseguía un beneficio en términos de mejoría sintomática significativamente mayor que aquel que se lograba con un placebo. Y esto se observaba de manera muy temprana. Ya en la semana 4, es decir, tras 4 dosis de medicamento, los pacientes que tenían tratamiento con el fármaco activo estaban mejor que los pacientes que recibieron placebo. El objetivo primario de este estudio en términos de remisión histológica era lograr tener menos de 6 eosinófilos por campo de gran aumento, y esto se logró en un 60% de los pacientes tratados con dupilumab. Es cierto que en este estudio se ensayaron otras dosificaciones del fármaco y así hubo algunos pacientes, representados aquí en barras de color azul, que se inyectaron dupilumab cada 2 semanas. La eficacia en términos de mejoría histológica fue completamente comparable. Como ven, 60% también de remisión histológica definida como menos de 6 eosinófilos por campo de gran aumento en semana 24, y si ponemos el objetivo de tener menos de 15 eosinófilos por campo, que como saben ustedes es el umbral a partir del cual diagnosticamos la enfermedad, el 80% de los pacientes con cualquiera de las dos dosificaciones conseguía este objetivo. En aquellos pacientes que se trataron con placebo y que no respondieron en una primera fase, se logró la misma eficacia una vez que fueron cambiados al fármaco activo. Sin embargo, solamente la dosis similar pudo demostrar una diferencia significativa en comparación con el placebo en cuanto a la remisión de los síntomas, y por ese motivo fue la única dosis aprobada oficialmente para el tratamiento de la esofagitis eosinofílica, inicialmente en Estados Unidos por la FDA y posteriormente en Europa y en otros países europeos. Más allá de las 24 semanas, 6 meses, tenemos datos de eficacia de dupilumab hasta 1 año y sabemos que prolongar la duración de la terapia aumenta el beneficio de la misma en términos de remisión histológica. Pasamos de un 60 a un 85% de remisión definida como menos de 6 eosinófilos por campo de gran aumento si vamos a 1 año de tratamiento, y si consideramos el umbral de tener menos de 15 eosinófilos por campo, al cabo de 1 año el 100% de los pacientes habrían conseguido este objetivo terapéutico. Hay distintas indicaciones para el tratamiento con dupilumab que han sido definidas en la literatura y resumidas en esta línea, pero desde mi punto de vista, probablemente la mejor opción es aquel paciente que presenta múltiples enfermedades atópicas capaces de manejarse con un mismo fármaco, siempre que cualquiera de ellas, la esofagitis eosinofílica u otra, esté pobremente controlada, y aquellos pacientes que presentan fallos a las alternativas terapéuticas actualmente disponibles, que es una proporción realmente pequeña si se utilizan de manera adecuada los tratamientos con IVPs y con comprimidos bucodispersables de budesonida. También es cierto que una proporción importante de pacientes hoy día están recibiendo dupilumab porque han presentado alguna complicación, fundamentalmente en forma de candidiasis esofágica, tras el tratamiento con corticoides tópicos deglutidos. Como en cualquier enfermedad crónica, hay que considerar que en la esofagitis eosinofílica los tratamientos son dinámicos y que un paciente puede comenzar con una alternativa y cambiar a otra a lo largo del tiempo. Por ejemplo, pacientes con un fenotipo estenosante se deberían tratar en primera línea con corticoides y dilatación, y una vez que la enfermedad está controlada, tal vez podrían cambiar a otras alternativas. Es decir, no se trata de mantener un tratamiento desde el principio hasta el final si resulta eficaz, sino que se trata de acompañar al paciente a lo largo de su experiencia vital, ofreciéndole la mejor alternativa disponible en cada momento. Y en cualquier enfermedad crónica contemplamos siempre dos distintas fases en el tratamiento, que es la inducción y el mantenimiento. Y esto hay que tenerlo claro desde el principio, tanto el paciente como su médico, porque es muy importante saber que la terapia que resulte eficaz en la inducción deberá mantenerse a largo plazo de manera ideal, y si el paciente no va a ser capaz de mantener esta terapia, habrá que plantearse alguna otra alternativa. Este es el algoritmo de manejo que aparecerá en las futuras guías europeas de esofagitis eosinofílica y que recogen que una vez controlada la enfermedad desde el punto de vista sintomático e endoscópico e histológico, se plantea la necesidad de un tratamiento de mantenimiento con los fármacos a la mínima dosis eficaz o con la eliminación exclusiva de los alergenos alimentarios que causan la enfermedad en cada paciente particular. Tenemos datos sobre la eficacia a largo plazo de los IVPs, derivados del estudio que anteriormente les he presentado, y que nos dicen que una vez alcanzada la respuesta con una dosis doble de corticoides, si se reduce esa dosis a la mitad, hasta un 70% de los pacientes son capaces de mantener su enfermedad controlada con este omeprazol o fármaco equivalente. En el que el 30% de pacientes que pierden la respuesta podemos recuperar esta volviendo a las dosis dobles iniciales. También tenemos datos a largo plazo del tratamiento con corticoides. Estos son resultados del estudio que desarrolló la budesonida en comprimidos bucodispersables. Una vez finalizada la fase ciega de un año, todos los pacientes tuvieron la posibilidad de recibir medicación abierta real a dosis de medio miligramo o de 1 miligramo 2 veces al día durante un periodo de 2 años adicionales. Y como ven ustedes, desde el punto de vista de remisión clínica, los pacientes se mantuvieron sin síntomas de manera continua a lo largo del tiempo. La histología se mantuvo en remisión en la gran mayoría de los pacientes a lo largo de este periodo, con una proporción bajísima de pacientes que no estuvieron en remisión histológica profunda, y la endoscopia también se mantuvo normal a lo largo del tiempo. Pero hay que advertir que existe un gran problema en la adherencia a los tratamientos en pacientes con esofagitis eosinofílica, como pone de manifiesto este estudio con pacientes holandeses, donde nos muestran que a largo plazo solamente un 35% de los pacientes se mantenían adherentes al tratamiento con corticoides tópicos y un 41% al tratamiento con dietas. Y además, esto ocurría porque muchos pacientes creían tener menos necesidades terapéuticas, percibían estar mejor de lo que realmente podían estarlo, o en los pacientes más jóvenes, que tenían más riesgo de que una vez se encontrasen mejor pudiesen interrumpir la terapia. Ya para terminar, solamente resaltar estos 4 mensajes, que los IVP son en este momento la alternativa de primera línea que se utiliza de manera más frecuente en los pacientes con esofagitis eosinofílica, con una eficacia muy bien reproducida pero modesta de un 50%. La eficacia de los corticoides tópicos es muy alta, pero depende muchísimo de la formulación que estamos utilizando, y la utilización de fórmulas adaptadas a su liberación esofágica permite reducir las dosis que vamos a emplear. Más del 90% de los pacientes pueden mantener la esofagitis correctamente controlada con un adecuado manejo de los IVPs y de los corticoides tópicos, y en la terapia con dupilumab ofrece la ventaja adicional de permitir el tratamiento conjunto de varias comorbilidades atópicas asociadas en un paciente que presenta esofagitis eosinofílica. Muchas gracias por su atención.
Thank you so much, Dr. Lucendo. That was a fantastic presentation. All of these presentations have just been so wonderful today. Victor, you have joined me here for the Q&A time.
Hi everyone. I didn't have the chance to introduce myself, but I'm Víctor Gascón, the CEO at GAAPP, and I will be very happy to conduct this brief Q&A session. We have a lot of questions today. We will try to answer as many as possible, probably 6 or 7 now. But any question that we cannot answer live, we will answer you privately by email. So we will not leave you hanging. So the first one, I don't know if Professor Racca is here. The first one will be for you. Is from Adriana Duelo. She says, thank you very much for the presentation. I wanted to ask if you have any clinical experience with the application of well-structured and personalized low histamine diet by dietitians or nutritionists in patients with EoE. In particular, have you observed any benefits on symptoms or inflammation control in certain subgroup of patients?
So this is an interesting question, but I have an answer that may not be pleasing. The problem is that low histamine diets do not have a role at the moment in eosinophilic esophagitis. The first reason is that histamine has not a real role in eosinophilic esophagitis. Antihistamines as medication have been tried, but they did not work. And we know that histamine is not a major actor in the inflammation. And so I would not recommend at all low histamine diets for the treatment of EoE.
Thank you, doctor. Now we are going to go to one of our Q&A questions. Just give me a second. So this is from Alejandro Fernandez. I think this is for anyone who wants to answer. So is there any medical explanation for the decrease in atopic symptoms such as asthma, atopic dermatitis as you get older, but EoE is sustained chronically?
Usually, but not always, allergies do reduce the symptoms burden going on with age because our immune system gets older and becomes less reactive. But this is not seen in EoE, I agree, but also in many other conditions like asthma usually does not decrease its intensity and its level with age. And there is also a kind of non-allergic asthma that actually starts after the age of 50. So, and it's a kind of asthma that looks more like EoE as inflammation type. So this kind of type 2 inflammations that are less dependent on allergens do not decrease with age. It is correct.
Perfect. Thank you. So the next question, I think that will be for Lucendo. This is from someone you know very well. So this is from Eva Garcia from AEDESEO. There is 2 questions, but we can make it into one. So the prevalence of EoE is currently considered, so given the prevalence of EoE, is it considered still a rare disease or it depends on the geography globally versus the US, the EU, or Asia Pacific? And also, do you think the EoE is heavily underdiagnosed and the real prevalence is actually much higher? Or anyone can take it. Sorry.
Gracias, Víctor. Creo que la esofagitis eosinofílica es bastante similar en todo el mundo y que las diferencias que se han descrito, en mi opinión, dependen mucho de la capacidad para detectar la enfermedad. Creo que todavía existe mucho infradiagnóstico, como el doctor Dellon ha señalado, y la oportunidad de desarrollar estudios epidemiológicos de base poblacional no es sencilla en todos los sitios. Estoy convencido de que la esofagitis eosinofílica seguirá aumentando su prevalencia a lo largo de los años porque los pacientes son jóvenes, es una enfermedad que no es letal y los casos se van acumulando, pero al mismo tiempo porque la incidencia también está aumentando de manera progresiva. Nosotros hemos observado en nuestra área geográfica, donde venimos haciendo estudios epidemiológicos periódicos sobre nuestra población, que la incidencia se ha multiplicado por 4 en los últimos 10 años y que la prevalencia se duplica por cada década, con lo cual creo que todavía estamos lejos de alcanzar una cifra definitiva y esto podría reproducirse en otras áreas geográficas perfectamente.
Gracias, doctor. Thank you, doctor. So the next question is also from our Q&A. So this is from Miriam Gonzalez. I'm going to translate this for you. So this is originally in Spanish. It says, for other pathologies, I have problems to conduct an endoscopy. Is there any other way to diagnose currently?
So right now, the only way to definitively diagnose EoE is with an endoscopy because we need to see what the esophagus lining looks like. We need to be able to take those biopsies and have our pathology colleague look under the microscope to look for the eosinophils and detect changes. And at the same time, that endoscopy lets us make sure there aren't other things that could be causing the clinical picture. There are tests that are now available that are not endoscopically based or are less invasive that may help us monitor the disease going forward without doing the traditional sedated endoscopies, but these tests can't yet be used for diagnosis.
Thank you, Dr. Dellon. I'm going to make two more questions, and I know we are a little bit over the time, so I really appreciate everyone for staying here. However, Doctors Dellon, Racca, and Lucendo, if you have any other urgent matters to attend, we will understand. So the next question is a very interesting one, and then we get very often. I'm also going to translate it. It was originally in Spanish, so everyone can answer this. So this says, what evidence do we actually have about the safety of different treatments during pregnancy? So in the clinical practices, is it normal to maintain the treatment, sustain the treatment, sorry, during pregnancy, or or it gets adapted or changed regarding patient and the state of gestation? And with the available evidence, is there any therapeutical focus that you should consider?
So I can start with that. There's very little evidence in EoE
I think Dr.
directly.
Dellon, if you can take this one, because I think Alfredo just
Okay.
internet
Yeah,
is
there's very little evidence of this question in the data for EoE. What we know is there's been a few small studies of pregnancy published in EoE, and in general, EoE does not seem to flare up during pregnancy, and it's like other allergic and autoimmune conditions where it seems to be less active. And that's of course because the body tends to be more immune tolerant when the baby is growing there. And then it can flare up afterwards. But generally, it doesn't seem to affect the ability to get pregnant or the developing fetus. In terms of the treatments, we know in general that proton pump inhibitors and corticosteroids, especially topical steroids like we use in EoE, like you heard from Dr. Lucendo with a very low dose, are likely okay in pregnancy, but it's really going to be a choice between the woman and her doctor and what they feel is comfortable. But And then we have really no data on dupilumab right now in pregnancy. There is a large global registry where they have finished enrolling, but they have not finished analyzing the data because follow-up is ongoing to see what happens. So what I typically will tell my patients who are thinking about getting pregnant is, number one, I want to make sure the EoE is under control the best it can be before they start conceiving. And if they have strictures, I make sure they're dilated because what we don't want is a food impaction and emergency endoscopy during pregnancy. And then it's a discussion about whether they want to continue their medications or not. And it's a personal choice. Some continue, some don't. And if they flare during the pregnancy, I think it's pretty safe, especially second and third trimester, to add PPIs or a topical steroid. I'd be interested to hear what everybody else thinks.
Okay, is there any comment to that, Dr. Racca or Dr. Lucendo, or you want me to go to the next last two
No, I
questions?
completely
I agree
agree.
completely.
That's always
Diet
good to hear that you agree.
Diet can be continued always with a nutritionist or a dietologist supervision, obviously. PPIs can be used, and topical steroids, we know from asthma patients that they should be safe. Of course, there are no data on EoE formulations that are the same drug but in a different formula. And so they are probably sure safe, but there is no real big data for this.
Thank you, Dr. Racca. Last two questions. We promise it's the last two. We will not drag this any longer. And again, I appreciate for your time. So the next question is also from Spain and is regarding something that a patient has researched online. This is not a self-reported symptom. So has there been reports of inflammation and pain in the plantar joint of the feet and the Achilles tendon area associated with dupilumab use? And what will be the appropriate protocol for these patients? I don't know who wants to take that one.
Ok, dupilumab es un fármaco seguro. La experiencia de la seguridad de dupilumab procede de su utilización durante unos cuantos años, fundamentalmente en otras enfermedades alérgicas diferentes a la esofagitis eosinofílica. Hay una especial efecto adverso bastante particular, que es un tipo de conjuntivitis, que realmente es sequedad ocular, que está restringido a pacientes con dermatitis atópica y que no se observa cuando se utiliza en esofagitis eosinofílica. Y la siguiente efecto adverso en frecuencia es dolor en el lugar de inyección. O sea, no parece que sea tampoco muy grave. Existen algunos pacientes que pueden presentar efectos paradójicos y probablemente este sea un caso que debería ser valorado específicamente por el médico de este paciente, pero creo que no podemos generalizar que este sea un efecto adverso que podamos ver de manera habitual.
Thank you, Professor Lucendo. And the last one, this is few people in the chat ask these questions in a different way. So I'm going to try to summarize. So this is about the safety of changing your diet for protein shakes. Like, what is your opinion on changing or modifying your diet using the protein shakes? Or yeah, I don't know if I made myself clear.
Bueno, sí, vamos a ver. El tratamiento dietético de la esofagitis eosinofílica consiste en eliminar los componentes alergénicos que con más frecuencia producen la enfermedad, que concretamente son proteínas. Es decir, el principal alimento que produce la esofagitis eosinofílica es la leche y en concreto las proteínas de la leche, seguido por proteínas del trigo, proteínas del huevo, proteínas de la soja y la legumbre y en mucha menor medida de frutos secos o alimentos de origen marino. es cierto que las proteínas están contenidas en el alimento juntamente con otros componentes y eliminarlas de manera específica no se puede. Creo que en este momento la recomendación sería eliminar alimentos concretos, identificables, es decir, leche y derivados de la leche o alimentos que la contengan en su composición, o trigo o alimentos que la contengan en su composición, más que hablar de tratamientos dirigidos de manera concreta a proteínas específicas frente a las que no podemos decir nada en base a las pruebas científicas disponibles.
Thank you, Dr. Lucendo. So I think we could be like 6 hours answering questions, and everyone has a lot of very valid and interesting questions. Again, we will not leave you hanging. We will get all the unanswered questions, and then we will reply you by email. Whatever we can reply from the patient organizations, we will try to do so. For those from Spain, we will try AEDESEO to do it, and the other countries, their own respective organization. And for those clinical questions, we will ask the doctors if they kindly help us with that. So now I give it back to my colleague Stephanie for the last part of the webinar, and Zoraida as well. Thank you.
Thank you, Victor. And thank you to all of our presenters today. Thank you so much. We just wanted to share with you quickly a few resources that we've created or that we know of that you might be able to share with your communities. The first is a website. It's eoeday.org, and contained on that site, you'll see lots of resources, materials that are free for you to use, free to download, and free for you to share with others. We encourage you all to go to that site and help to make an impact. Also, I wanted to share, I saw on a few of the presenters' slides, they were talking about care paths and that type of thing. So we have created a care pathway that is on one side for patients so that they kind of understand where they are in the scheme of things. And then on the flip side, it is for physicians. So we have this also available on the website I just mentioned, eoeday.com. So you can go and download this in a variety of languages. We have it currently English, French, Spanish, German, Hebrew, Arabic. You can see all of them here listed. So please do take a look at that, and we hope that it is very helpful as you navigate your EoE journey. A couple of other things that you will find on the website. We have 2 videos, and Victor, I think he alluded to them earlier on the call. 2 videos that were prepared this year for EoE Day, and they are just beautifully done. And I think that they really speak to the urgency behind this activation on Awareness Day. The first one is called Knots. There is no speaking in this. It is simply animation, but it really focuses on the lived experience of someone who has EoE. And then the next video is, whoops, it's going to try and play. I don't want it to do that. The next video is Food Shouldn't Hurt. And so you kind of walk through in the shoes of different individuals who are living with EoE and see how it's impacting their day-to-day life. So I encourage you to take a look at both of those videos, share them with your communities, share them with people that you come in contact with. These are great storytelling tools. I also would like Zoraida. Zoraida, are you on? Do you have your microphone?
I'm inviting her. Just give a
You're inviting her,
few seconds
okay.
more.
We've worked very closely with AEDESEO throughout the course of this and just want to make sure they have a chance to speak to you all.
¿Me escucháis ahora?
Hello.
Hola, buenos días.
Thank you.
Me has dado paso, ¿verdad, Stephanie? Ok. Vale.
I hear you, yes.
Soy Zoraida Gómez, soy la presidenta de AEDESEO y quería sobre todo dar las gracias, cerrar este webinar a los ponentes, a todas las sociedades que nos han apoyado un año más y animarnos a difundir, a hacer divulgación y concienciación sobre todo de la EoE y que comer no debería doler. Muchas gracias a todos y nos vemos.
Thank you so much. Thank you for the support for this World EoE Day. We also want to thank all of the members of the EoE Day Alliance. They are listed here. Many of them we are growing each year, so that is a good thing to see. And we also want to thank our industry partners for the EoE Alliance efforts. I think we are well over time. Thank you all. Drs. Dellon, Drs. Lucendo, and Dr. Racca, we thank you so much for being here and sharing your expertise with us. And we'll see you again very soon. Thank you all.
Thank you, everyone.